Thanks, Dr. Goldenberg. My name is Mike Metcalfe. I'm a third-year urology resident. We have the pleasure today of having Dr. Phillips. He's head of infectious disease. He sat on the 2010 committee to design the Candidemia guidelines. So it's a pleasure having him, as well as Dr. Ted Jones, who's going to help us run through some of the pathology of our first case. I first heard of fungi as a third-year medical student. I was answering the junior resident's pager, who was currently scrubbed in the OR. I got the call saying, can you come help us see this 81-year-old guy with fungi up on the ward? I said, oh, neat. I'll come see it right away. I learned 3 things that day. 1, never answer the resident's pager and accept consults from CTU. Number 2, that actually Candiduria isn't always so benign. And 3rd, that resident later went on to fail the Royal College exams. Genitourinary Candidiasis, it is common and it can be concerning. Candida is the 4th most common cause of nosocomial infections in the world. 5% of urine cultures yield Candida in a hospitalized patient. And this is the most frequent urinary isolate in ICU patients. 3 to 10% of candidemia comes from a genitourinary source. And when candidemia does occur, it's associated with a 35 to 60% mortality. It's attributed as a cause to 22 to 35% of these cases. So my objectives today. I recently attended a CBC Massey Lecture Series by Dr. Mark Turek. He's head of cosmology and theoretical physics at Stanford University. His objectives were to help guide the listener through the understanding of the universe and help them gain understanding to its origin as a singularity. Hopefully these are a little bit more achievable. We'll just hope to understand the risks of Candiduria and Candidemia, outline its medical management, describe surgical and endoscopic options, as well as review surgical prophylaxis and management of fungal infections in certain urological populations. I'd like to begin a case. Many of you are familiar with this case. He's a 70-year-old male with multiple comorbidities, baseline renal dysfunction, who in February 2011 had essentially recurrent ureteric strictures from an impacted stone. Everything had been attempted with this gentleman. He had residual renal function, so he underwent left auto transplant from his left kidney to his left iliac fossa. 9 months later, he was readmitted with pyelonephritis. It was culture negative, so he sent home on ciprofloxacin. Came back a month later, was readmitted with fairly severe pyelo, fever, chills, and renal failure. He was treated with broad-spectrum antibiotics and was admitted on the CTU. His initial cultures were all negative, so his broad-spectrum antibiotics included ceftriaxone and ampicillin. Ultrasound showed mild bilateral hydronephrosis, but nothing concerning. 3 days later, his blood and then eventually his urine became positive for yeast. So he started on fluconazole at that point. As you can see, he was not healthy, but had no real immune suppression other than the diabetes. That and his baseline renal dysfunction were his main comorbidities, as well as some AFib. Here's a CT scan that was done after his ultrasound. If you look at the right kidney, it shows proximal hydroureter, hydronephrosis, and stranding. His left kidney, his auto-transplant kidney, showed gas in the collecting system, no evidence of stranding. There was no enlargement of the kidney itself. Here it is again in its transverse view. Note, at this time he just had low-grade pyelonephritis, no evidence of a gas-forming organism on culture, and he'd only had yeast in his blood and his urine. But he still wasn't responsive to systemic therapy. There was air seen in his bladder at the time, so we were worried about emphysematous pyelitis, although initial suspicion was low given that he was clinically well. So in order to confirm that this air in the kidney was just a refluxing air from the bladder and the Foley balloon within the bladder, we did a cystogram. This revealed a freely refluxing ureter and no evidence of filling defects. Later, he went on to have a repeat CT scan in 2 days to confirm that the air was gone and to reevaluate his hydronephrosis in his remaining native kidney. This showed residual hydronephrosis as well. So therefore, we hadn't evaluated this right kidney yet, so we went on to retrograde pyelogram. It showed partial obstruction, no evidence of significant filling defects. Given that he was getting more clinically unwell and still not responsive to therapy, a stent was inserted. After a stent, his clinical status deteriorated. He had an ICU admission. Ultrasound upon admission to ICU showed hydro and presence of debris within the collecting system, despite the stent being in place. He had a nephrostomy tube inserted. This came positive for yeast in the urine, and so we started with amphotericin irrigation. He was continuing to decline. He had multi-system organ failure. ICU were worried about source control and had organized an indium scan. This is a white blood cell technician or indium labeled scan, where essentially the white blood cells are labeled and they go to any areas of significant inflammation. His right kidney was the only thing that lit up on this scan. At this time, we had broad spectrum IV antibiotics that were empirically treated for the yeast. He continued with positive blood cultures and urine cultures. His urinary system was completely optimized in terms of drainage, and he had local amphotericin irrigation, and he did unwell. So we went on to nephrectomy at this point in time. Dr. Jones is going to run through some of the pathology of the nephrectomy specimen. We'll start with the ureter from his auto transplant back in 2011. Yes, Dr. Jones.
So in January 2011, we received a 7.5 centimeter length of ureter, and this segmental resection showed chronic inflammation, all these new cells and lymphocytes in the wall, and diffusely eroded mucosal surface. Small areas of remnant urothelium were identified, and they were benign. The lumen was filled with necrotic eosinophilic coagulum, and there's considerable histiocytic inflammatory response with foreign body reaction and evidence of old hemorrhage with reactive fibrosis in the wall. All of this was taken to be evidence of urinary tract instrumentation with stents in place, inflammation. The exact nature of the coagulum in the lumen wasn't entirely clear, although the history was that there had been a stone, and it was assumed to somehow be related to that. I went back to this specimen given the subsequent course of this patient, and on this left ureteric specimen did a fungal stain, and the fungal stain in this necrotic tissue is negative. Now in January 2012, we received the right total nephrectomy specimen, which on gross examination was noted to have distended calyceal collecting system with hemorrhagic necrotic debris in the lumen of the collecting system throughout the kidney. Histology demonstrates an acute on chronic pyelonephritis. You can see glomerulus there. The tubules are filled with mixed inflammatory cells, including neutrophils, and there is a tubular interstitial pattern of inflammation with edema and inflammation of the interstitium. As well, there was granulomatous inflammation. As we see in this area, we have a nodular collection of epithelioid-type histiocytes, and it may be difficult to appreciate, but this is actually centered towards the medullary region on the urothelial surface, as we see in the upper left. A section of the collecting system shows a benign urothelial lining and a urinary space here filled with inflammatory material, which on higher magnification can be appreciated even with a straight H&E stain to contain fungal elements with hyphae, or perhaps one should refer to them as pseudo-hyphae in this instance, knowing that it is Candida and spores as well. This is further highlighted with the PAS fungal stain, and this in fact is forming a fungal ball within the collecting system. These elements were also within the inflamed parenchymal tissue of the kidney, and indeed many of the large blood vessels, these being veins, were filled with thrombotic hemorrhagic inflammatory material spilling through the walls, seen to better advantage at this higher magnification. This being the lumen of a vein, you can appreciate the interrupted smooth muscle bundles of the vein wall, and its partial destruction with inflammatory process effacing the anatomic structures. And one can appreciate on this silver fungal stain that the vein is plugged with fungal elements amongst the inflammatory material. Sorry?
Is this quite rare?
Yes, to see invasive fungal infection of the kidney, which appears to be an ascending infection, is very unusual. It is most often Candida can arrive in the kidney through ascending or hematogenous routes. It's unusual for Candida to be angioinvasive in this way. Other fungal forms such as Aspergillus or Mucor, particularly in diabetic patients, can involve the kidney, and they're the ones more typically angioinvasive.
Is there any sign of papillary necrosis?
Good point. There was no evidence of papillary necrosis or infarction of the kidney, and indeed sloughing of the papillae. And diabetics are at increased risk for development of what we call papillitis necroticans, can form a nidus for the development of a fungal ball in the collecting system, but there was no evidence of that on the histology. Sorry? I'm missing the fungal.
Bezoar.
Hmm?
Yeah.
Bezoar. Oh, bezoar. Oh, okay.
That's a counter.
Well, I just call it a fungal ball. Bezoar. No, I understand now. Sorry, my hearing.
I think that's what this slide's showing, though. Is in the collecting system,
well,
you can see the.
And grossly, these were identifiable. These were identifiable fungal balls in the collecting system. Very unusual. Very unusual. Yeah.
Thanks, Dr. Phillips. So that's a nephrectomy specimen. After his nephrectomy, he had many complications, as tends to be the case with invasive fungal infections. He did have a clot in the right atrium. This ended up not being fungal vegetation, but it was sort of simply blood clot, responded to anticoagulation. Unfortunately, he developed a retroperitoneal bleed being on the heparin for his clot. He received a tracheostomy for his prolonged ventilation. He had a rebleed from this. He had ESBL sepsis secondary to his pneumonia and continued hemodialysis. His candiduria persisted. At one point became flucanilazole resistant. He ended up getting stepped up to micafungin. He received a nephrostomy tube in his pelvic kidney, amphotericin irrigation again, and eventually was cleared of his candidiasis. He does have persistent candiduria, however, systemically well, and unfortunately still dialysis dependent. So, although this case is rare, Candida isn't as rare as I first thought. If you look at the hospital-acquired urinary tract infections in urology departments, this was taken from the EAU study where they looked at over 6,000 patients from 200 hospitals. And it's a prevalent study. They chose a Wednesday in November and they sampled everybody's urine. So every urinary, this is number 8 in terms of positive urinary isolates. They did found that at past antibiotic use and urinary catheters were at increased risk of Candida in the urine. It becomes more prevalent when you start to look at whether or not they're symptomatic. If you look at the number of patients that had positive Candida as a result of this urine in their blood, as well as systemic inflammatory response syndrome, Candida was the 5th leading cause at 13%. This is on the same realm as Klebsiella and Enterococcus. Now, this is in hospitalized patients. It's not an outpatient setting, and it doesn't include the critically ill. It doesn't include ICU patients. If you look at the epidemiology of urinary tract-related bacteremia in the ICU alone, Candida becomes number 2 on the list. All patients, 19.7. And here, which is slightly higher than other areas reported in the literature, they report a genus-specific case fatality rate of almost 50%. Elsewhere in the literature, in the critically ill, it quotes 7.5 to 17%. Canada did a very similar study to this, as opposed to only on about 63 patients, as opposed to the 320 patients done here. and they found almost the exact same results. So Candida can be quite concerning. And one of the main troubles with Candida is that its diagnosis can be elusive. Its clinical presentation is non-specific. They can have skin and eye lesions. They can have other symptoms of Candida elsewhere. Their lab tests are non-specific. About 50% have leukocytosis. Sterile cultures and tissue biopsy is the gold standard. However, the culture isn't as simple as it is. It's not very sensitive. It's only about a 50 to 70% sensitivity. And there's often a delay of about 48 to 72 hours, especially in fungal infections. There's other measures out there now to try and improve the sensitivity of the sterile site culture. The beta-D-glucan assay is approved, but it's not available to us, so at this point it's not clinically relevant. They've attempted PCR, and it's showing high sensitivity rates, but it's still very investigational. Imaging is an important adjunct. Fungal pyelonephritis is clearly identified on ultrasound. You can see a thin hyperechoic line at the mucosa. As well, they get loss of their corticomedullary differentiation and hypoechoic pyramids. Fungus balls, when they do occur, although they are rare, can be seen as non-shadowing echogenic foci within the collecting system. However, concerning with fungal infection is they can be said that they're metastatic. They have a tendency to invade and create other foci within the body. They can infect the bone, joints, CNS, heart, and almost any organ within the system. Specifically with regards to the endophthalmitis, about 30 to 40% of candidiasis patients develop endophthalmitis. 9 to 45% of these patients develop it if they don't receive therapy. However, if they receive early antifungal therapy, about 1 to 3% of the patients only develop endophthalmitis. Of these, the concern with endophthalmitis is the progression to retinal necrosis and retinal detachment. As a result, all patients with systemic candidemia should have an ocular exam performed by ophthalmology. If they are either symptomatic or they've had prolonged candidemia without antifungal exposure. I'd like to ask Dr. Phillips to come up and talk about advances in antifungal therapy and the use of medical management of...
How useful is the ophthalmological exam in terms of making a diagnosis? You're saying this is on a delayed basis as a metastatic?
You know, initial symptom. If they have, if you're worried about fever of unknown origin, if they're clinically in, they'll have risk factors, and they have endoscopic eye findings, it's very helpful. You can see the actual fungal balls right at the back of the retina. I don't have a number for you. Thanks, Dr. Phillips.
So in the last 15 years, this slide really summarizes the options that we have for systemic antifungal therapy going back to when amphotericin B was first introduced back in the late 50s. And you can see that most of the progress is within the last 15 years, since 1997, where we've had introduction of a number of lipid formulations of amphotericin B, which come with lesser toxicity. The three different candins that have been marketed, initially caspofungin, and then more recently microfungin and nigellofungin, and then additional azole class compounds such as voriconazole, posaconazole. So lots of good news in terms of newer options, but from the urologic perspective, what are the drugs that are most useful? And there's still the ones that were initially developed back in the old days, amphotericin, 5-flucytosine, and fluconazole in 1990. So lots of new progress, but it isn't really helping managing urologic infections. In terms of what Candida species are responsible for urinary tract infection, at least at St. Paul's, our lab doesn't do species identification. In fact, a lot of times they won't do even genus identification for use in the urinary tract, since many of these are not of great importance depending upon the clinical situation. So the lab will work these organisms up, but it's often a phone call request to do that. And I don't believe that they're doing that on a regular basis here in the VGH lab. But these are some published data just giving an indication as to what are the most frequent. This is pretty similar to what we see in the distribution of Candida species in bloodstream infection, with albicans accounting for approximately half of the isolates, followed by glabrata, which has increased in some centers, particularly where there's been more in the way of azole use with fluconazole. And then the others, tropicalis. Parapsilosis shows up more often in blood than it's showing up in this study of urine cultures, and then much less often Candida krusei, which is known more because of it's a difficult organism. It tends to be more resistant. This is the sort of usual sort of distribution of susceptibilities for these different Candida species, and although often one hears about non-albicans strains of Candida being resistant to fluconazole, it doesn't apply to all of them. And you can see here that this is the fluconazole susceptibility here. Albicans, tropicalis, and parapsilosis are typically pan-susceptible to not just fluconazole, but most of the other azoles. It's glabrata that's more of a problem in terms of management. Krusei is predictably resistant to fluconazole, and glabrata is the most common of these non-albican species that might be an issue. You just look over at the other drugs that are relevant for urologic infections and treatment. 5-flucytosine is an agent that's relevant in some of these cases. And it's not active against all of the albicans isolates, but about 75% of them are susceptible. And then moving over to amphotericin B, the ones that are fluconazole susceptible are also amphotericin susceptible, as well as the others, but glabrata, krusei, and so on are not as susceptible as the other species. Now, this slide pretty well tells the story as to what antifungal drugs are going to be useful in the collecting system. And among the azole class of antifungals, fluconazole has some great characteristics. It's a very well tolerated drug, and about 60 to 75% of it shows up in the urine, which can give you serum levels, or rather urinary tract levels, that may be tenfold higher than what you achieve in blood. And blood levels are not that difficult to achieve and maintain compared to some of the other drugs. So you can get urinary levels that are, say, greater than 100 micrograms per ml. But in contrast, the other azoles like itraconazole, voriconazole, posaconazole just don't get in very well. Although these other drugs may work in the setting of disseminated candidiasis and candidemia that's not coming from a urinary source, and they may protect the kidney and deal with renal cortical involvement in disseminated candidiasis. These are not options that one would look to in terms of treating say, Candida pyelonephritis or an ascending infection. Like fluconazole, 5-flucytosine also is mainly excreted in the urinary tract, so you get good levels there. Bit of a drawback with this drug is that when it's used as monotherapy, there's a relatively low barrier to resistance. So after a week or two, you may end up losing its activity. And quite often, 5-flucytosine in the setting of candidiasis and certainly cryptococcal meningitis is used as a partner drug with amphotericin B. Now, looking at some of the improvements in terms of amphotericin formulations, liposomal amphotericin B is the most widely used here, and it's the best tolerated. But these newer formulations don't get into the urinary tract very well at all, and are generally not recommended for this indication. And the echinocandin class, of which in Vancouver Coastal we have micafungin because of its cost advantage, the echinocandin class of drugs don't get excreted into the urine. So again, not an attractive option for urinary tract infection. So these are the three that we generally rely on for urinary tract. In terms of the guidelines for management of various forms of invasive candidiasis, in the setting of candidemia, there are a number of considerations to take into account, depending upon hemodynamic stability, neutropenia, and so on, are listed on the slide here. And these decisions in terms of management are generally made before species identification is made in the person who has a positive blood culture. But notice the sanctuary sites. If the concern is that the infection is involving, where is this pointer? Is involving either central nervous system or urinary tract or the eye, these are three places where a number of the drugs don't penetrate particularly well. And although you see in terms of the management options, Candins or lipid formulations of amphotericin B, LFA and B, show up frequently as being, in recent years, often preferred options over fluconazole because of better spectrum and cidal activity. When you get to the urinary tract, the eye, or the brain, Candins and lipid formulations may not be as reliable. And for urinary tract, the emphasis is on fluconazole, amphotericin, or 5-flucytosine as mentioned. So in terms of management of Candida urinary tract infection, I'll first touch on asymptomatic Candiduria, which is the most frequent entity, which may show up in some instances in the healthy host, not so often, usually less than 1% of outpatient cultures. In the predisposed outpatient, and in the predisposed inpatient, it may show up in about 5% of urine cultures, but in the ICU, it may account for 25% of hospitalized patients. And then symptomatic Candiduria in the various sites, lower tract, upper urinary tract, and occasionally patients with prostate or epidiymo-orchitis. And then urinary tract fungus balls were already mentioned. And then Candiduria in the unstable patient. Now, asymptomatic Candiduria, the main mindset here should be looking for predisposing factors and trying to reverse them, and trying not to use antifungal agents because, as I'll come back to, it tends not to take you very far and is often an exercise in futility. In terms of the healthy host, at this point, got one here. The first step is just to get a second specimen to try to confirm the presence of Candiduria, and then screen for predisposing factors, diabetes, genitourinary tract abnormalities. In the predisposed outpatient who's already known to have risk factors for Candiduria, then controlling diabetes more closely. If there's been a recent course of antibiotic use, perhaps just repeat the culture down the road. Often it will convert to negative in the absence of any specific treatment. And then for the predisposed inpatient, again, modifying predisposing factors, trying to remove catheters, curtail antibiotics, particularly if they're unnecessary. And if they persist, then image the upper urinary tract, looking for more extensive involvement, and trying to limit antifungal therapy to those individuals who have more than just Candida colonization or cystitis, but have upper tract disease. The sort of exceptions to this would be people who are particularly high risk for Candida complications, and that would include neonates, neonatal ICU, where Candida in the urine more often represents disseminated disease, neutropenic adults, and also those individuals who are going to have invasive urologic procedures who have asymptomatic Candiduria, where treatment prior to the procedure would be recommended, as would, say, prophylaxing those with asymptomatic bacteriuria. The predisposing factors have already been touched on by Mike and are generally well known, but include diabetes, extremes of range of age, renal transplant, structural abnormalities, indwelling catheters, stones, bladder dysfunction, urinary stasis, and antibiotics. And in the ICU, this becomes a very frequent finding. So why not treat the asymptomatic funguria that's due to Candida in the hospital setting. And a lot of the house staff will just write the order for the fluconazole, quick, done, don't have to think about it. But this study, I think, shed some light on how unhelpful this tends to be in a lot of these patients. This was done by Jack Sobel and others from Wayne State about just over 10 years ago. And they took some 300 plus patients and randomized them. And they were, for the most part, they were asymptomatic or minimally symptomatic, typical medical surgical patient who ends up with a urine culture done and Candida shows up. So the fluconazole group got 200 milligrams a day for 2 weeks, and you can see that the eradication rates are shown here. At 14 days, it was somewhat better, 50% eradication compared to 29% in the placebo group, which was significant. And when you looked and broke it down according to who had a catheter, the catheterized group, again, did somewhat better, 39 versus 20. And the uncatheterized group eradicated in 63% versus 41. So yes, in the short term, it seemed to be of benefit. But the 2-week follow-up sort of told the story here. And there were lots of missing data, as would be expected. But for those who did have the 2-week cultures available, in the catheterized group, 61 versus 56, uncatheterized, 74 versus 72, no difference. There was no case of candidemia among this 300-plus group of individuals. None of them developed a fungal death or had pyelonephritis. So this group generally did not get into trouble with Candida-related complications. There was a mortality of about 8% in the group, which has been shown in other studies. So this is a population that tends to be generally not doing well. The Candiduria is a bit of a marker for major comorbidities. But intervening with fluconazole, analogous to intervening with antibacterials in asymptomatic bacteriuria in the same sort of population, doesn't seem to really take you anywhere. And at the end of the day, you're not having a significant impact on outcomes in the way of morbidity or mortality. But for those individuals who do have symptomatic disease for cystitis, fluconazole is the drug of choice. 200 to 400 milligrams a day for 2 weeks is recommended. Alternatives would be monotherapy with 5-FC, but 7 to 10 days would be the sort of usual duration there. Amphotericin B can be used in more stubborn cases, the occasional person who might not tolerate fluconazole or perhaps have a fluconazole-resistant isolate. And there are sort of lowish doses of amphotericin B in the 0.3 to 0.6 range for even as short as a day may be effective. This drug stays around in the urinary tract for a couple of weeks, so the duration can be anywhere from 1 to 7 days. The use of amphotericin B bladder irrigations was something that was done more in the past when I was at Mike's stage of training, but it's generally gone out of favor. Might be occasionally used in people who have very resistant isolates where fluconazole or 5-FC aren't an option. But it's inconvenient. The nurses hate it. The patients don't like it, and so it's generally gone out of favor. There might be a role for it more in the, say, upper urinary tract installation in the setting of, say, pyelonephritis, where there might be a nephrostomy tube in place, but generally we rely on systemic treatment for that. In terms of pyelonephritis, again, fluconazole at 400 milligrams a day for 2 to 4 weeks, amphotericin B being the alternative, with or without 5-flucytosine. Note that if there is renal impairment, the fluconazole dose should not be reduced. For systemic infection, there is a dose reduction. So with significant reduction in GFR, the fluconazole dose, if you were wanting to dose at 400 a day, you might dose at 200 a day. But that's not recommended in the setting of a Candida urinary tract infection because the excretion of the drug in the urinary tract is greatly reduced in the presence of reduced GFR. So you should keep the dose at 400 even in the even in someone with very low GFR, and there's no great concern about toxicity. We use doses of 800, 1200 a day in normal renal function for cryptococcal meningitis, and it's quite well tolerated at those doses. Occasional patients may have prostate or epidiymo-orchitis involvement. This is getting repetitious. Again, it's fluconazole or amphotericin B. Duration is not well worked out here, but these recommendations are really based on case reports. There are no large trials here, and surgical drainage has come up as a frequent recommendation in this literature, particularly when abscesses can be demonstrated in the prostate. Now, in terms of the intensive care setting and the concern about invasive candidiasis, perhaps in an individual who has one or another positive site for candida, such as urinary tract or evidence of colonization in the sputum or elsewhere, if the question comes up, particularly for ICU people or infectious diseases, this person who has ongoing unexplained febrile illness despite broad-spectrum antibacterial therapy, and in the ICU, most of these people have one or multiple risk factors for invasive candidiasis. When do we begin empiric antifungal therapy? And given the limitations of what we have diagnostically, as Mike summarized, we are still in this conundrum of do we start fluconazole or a kind of candida like micafungin, or do we wait and see what comes up in blood cultures over the next few days? And although there's been progress over the past 25 years or so, it's still a lot like 1985, where you're at the bedside making a kind of an educated guess as to whether or not you use one of these drugs empirically, because these newer serologic techniques, or PCR, remain unavailable. And the problem with the delay in these sort of cases is shown on this slide, and there are some half a dozen studies showing the same sort of result. You've got mortality on the vertical axis, and the delay in initiating an antifungal drug, in this case fluconazole, is shown here. Now, the delay is if you draw the blood culture, say on Monday, if you start the antifungal on the day you draw the blood cultures, the mortality was 15%. These are in people who ultimately are shown to have candidemia, so their blood cultures went positive. If the blood culture is drawn here, but the antifungal starts the next day, the mortality went to close to 25%. And if you waited 48 hours, 35%, and then up to 40%. This same sort of thing has been shown quite consistently with bacteremic disease and in sepsis patients, and just showing that critical timing issue in terms of survival. And when you don't have adequate serologic techniques, you end up with clinicians doing studies based on risk factors, and this is an example of one from Spain, taking sort of a bedside assessment of risk factors, and based on odds ratios in a validation study assigned a score to an individual patient, and you can see that you might have an incidence of invasive candidiasis down around 2%, but for risk factors adding up to 5 or more, 24%. So this sort of thing is not widely sort of established and used in multiple centers, but this is the way this has been going, while clinicians keep waiting for better serologic techniques to make a rapid, reliable diagnosis. So I'll stop there.
Dr. Masterson, you had a question?
That's right. Is amphotericin still the empiric drug of choice for irrigation?
Well, that's the one that makes the most sense for irrigation, because you're going to get much higher concentrations than what you could deliver by intravenous or another route. Whereas flucytosine and fluconazole, you can get to good levels in the urinary tract without having to directly instill it.
Yeah, to answer your questions, Dr. Nigro, Dr. Masterson, yeah, they're still using amphotericin. They haven't been able to find a dose. They have looked at it in a couple smaller studies, but in terms of large series or even randomized controlled trials, it still hasn't been done. It's still recommended in the guidelines that if after they don't respond to fluconazole, that you can insert a nephrostomy tube and irrigation is appropriate adjunct. This is most recommended in settings of obstruction. As well, they've recommended streptokinase, which in the setting of a recent nephrostomy tube I wouldn't recommend, and they've also recommended mechanical irrigation. There's also quick studies on endoscopic management, which is percutaneous extraction of fungus balls. And this is only very limited again in very few case reports. Dr. Afshar asked him, he said he's had to do 2 in his time at Children's Hospital. Essentially, it is deemed to be pretty safe. I did read one case report where they did it recurrently for recurrent fungus balls, and unfortunately the patient bled, requiring a stat nephrectomy with complicated sepsis and hemorrhagic shock. And then lastly, I just want to touch surgical management of Candida. There is a couple indications for it. Nothing, again, proven in literature. If you read the literature, they talk about creating bilateral chelicectomies or partial cystectomy for a refractory Bezoar. Essentially, if it's not responding to full medical therapy, if the patient's doing unwell and they have disseminated disease, and you've isolated the source to the kidney, and there's evidence of invasive disease, or the kidney is not functioning, then it's recommended for a nephrectomy. The last slide is antifungal prophylaxis prior to urologic surgery. Do we need to do it? Should we? Essentially, if it comes up on preoperative urine culture sensitivity, then yes, it should be treated as Candida Prostatitis. This can be done preoperatively, so I'll recommend catheter change, systemic fluconazole, PO, for a couple days. They don't need to do the full 2-week course preoperatively, and then at the time. And the reason for the preoperative starting is because of the slow-acting course of fungal disease. Any last questions?
It's an option. Ureter calycostomy. How the hell do you marsupialize a calyx to the skin?
I read the case report, Dr. Masson. It was one paragraph. Essentially, it was in a pediatric population, and I don't know how they did it. They didn't describe the technique. They said they did it, that it worked. I was hoping that somebody would.
Any other comments or questions? Very practical rounds. Thanks very much, Mike and Dr. Phillips. It's not a common issue, but when it happens, patients obviously can get very ill. I forgot to mention earlier, there was some sad news recently. Most of you young people won't know Henry Ballin, but certainly some of us older ones. Henry passed away last week. And Henry was a nephrologist here at Vancouver General Hospital, a great friend of urology for many years. Those of us who trained here a generation ago, I guess now, John, and with Dr. Sullivan and Dr. Wright and McLaughlin, we had a lot of times where Henry bailed us out, and was always there for us. So very sad news. I'm not sure when the memorial service is, but Henry was a great friend. Again, next week, rounds will not be in here. Rounds will be at the Diamond Center. It's combined rounds with all the other surgical services. And then 2 weeks from now is our visiting professor. And it's a hassle, but we have to do the assessment forms. So either hand them in to me, keep a copy, the yellow copy for yourself in your MOCERT files, and or you can just email them or fax them into the office if you want to do them later on. And thanks again to Mike and Peter.